there's also competition in the field because 2 other treatments have been approved meanwhile, at least in the United States. The approval for pembrolizumab in Europe is expected in the next weeks because there's a positive CHMP opinion out already for the drug, but nivolumab is likewise approved in Europe. So we have the choice of either targeted therapies or PD-1 driven therapies, but what's your impression about Checkmate 238? I'd like to ask Mike now. 238, the data which have been presented by Jeff Weber for the first time a year ago at ESMO in Madrid. And then I would like to continue in asking if you see any differences to Keynote 054 on pembrolizumab, which has been presented by Lexagamont this year. And then we can compare if there's any differences between the PD-1 antibodies and what is your choice, your first choice for BRAF mutated patients.
Yeah, the design of the 2 studies was quite different because the Checkmate 238 study, again, compared adjuvant nivolumab for a year versus adjuvant ipilimumab, and so has actually a control arm of an active therapy, whereas the Keynote 054 study compared adjuvant pembrolizumab versus placebo. And so to start with, we're having a different comparator. The second difference being that the Checkmate 238 study actually didn't include patients with 3A disease. It was 3B, 3C, and stage 4 NED, whereas the Keynote 054 did include 3A with at least 1 millimeter of lymph node burden, 3B, 3C, but not stage 4. So again, a difference in sort of the design of the trials, both in terms of the patient populations and the comparators, both showing again that adjuvant PD-1 is very safe and very effective. Clearly, again, with the Checkmate 238, immediately replaced adjuvant ipilimumab as an adjuvant therapy option with adjuvant PD-1. And again, I think that, again, we use it quite routinely in the US. Again, not adjuvant pembrolizumab, not approved at this point in the US, but I agree probably to be approved in the near future.
Yeah. So we need to say that adjuvant ipilimumab high-dose treatment for 3 years was never approved in Europe. It was not even being submitted to the agencies, and therefore it's not an option in Europe, just to clarify the difference between the US and Europe at this point of time.
One other sort of just wrinkle to throw in there as well was the supplemental biologics license and agreement that Bristol Myers Squibb got in place around the dosing schedule of nivolumab, which is also slightly different, which in the study they gave nivolumab every 2 weeks, and yet now we can give it every 4 weeks. And I think that actually has some impact on which gets used in clinical practice. The pembrolizumab is every 3 weeks, and some of these practical issues for patients between targeted therapy and even within immunotherapy start to become pressing because when you're engaging a patient, what do they want to do in terms of what's most convenient and quality of life for them? So I think you can't forget that.
Also, the observation period between the 2 trials on the PD-1 antibodies is different because there's long observation for nivolumab compared to pembrolizumab, which was released very early in New England Journal of Medicine. But do you see any differences, or you envision any differences in the activity and toxicity of these drugs?
I don't see a big difference between these drugs, and I think that the minor differences that we see around hazard ratios are sort of the usual variants that you're going to get within a clinical trial, also taking into account that the populations were very slightly different, with one including 3As and the other one including stage 4 NED. So I think those probably make the difference there. I think we could consider PD-1 antibodies a standard of care either way.
The other challenge in comparing the hazard ratios is that they were compared to different controls, and so that really makes it virtually impossible to compare the hazard ratios. I do think one of the things that, again, we're waiting for is to see overall survival data from these studies. So it's one of the powerful things with the COMBI-AD is actually being able to see overall survival data. Again, knowing that dabrafenib trametinib can extend survival in patients who develop stage 4 disease, it's a really important result, seeing that use in the adjuvant setting appears to be impacting long-term overall survival. And I think that's one of the key questions we still have on the adjuvant PD-1 data, is to actually see overall survival data.
Yeah, you mentioned a very important point. It's different study designs. But you know what Olivier Michelin from Lausanne, Switzerland was doing is he estimated with a very simple mathematic model, which was also done in Germany, the hazard ratio for nivolumab compared to placebo, because this was nivolumab compared to high-dose ipilimumab, and there was an EORTC study comparing high-dose ipilimumab to placebo. And it's very simple. You simply need to multiply the hazard ratios, and it comes up to 0.49. So it's in a very much in the same
It's the same as pembrolizumab
range.
then.
It's the same range.
Right.
And therefore, we don't expect difference, because in stage 4, honestly, we have no difference. It's the scheme's different, as you mentioned, but there's no obvious differences in efficacy and tolerability.
So just to your point, the NCCN guidelines, which will be coming out very shortly in the U.S., suggests that you can use pembrolizumab or nivolumab in the adjuvant setting, even though pembrolizumab is not approved yet, but it certainly will be. It certainly will be.
It makes sense.
So
It makes
maybe
sense.
you can address this. So one of the interesting things that we do with each day in the clinic is that these trials, even the trials that included 3A patients, required at least 1 millimeter tumor burden in the lymph node. That in actual fact, all of the trials, even those that included 3A, have not included those patients who have 3A disease but with less than 1 millimeter of tumor burden.
So the interesting thing is that the FDA approved both of these approaches, whether it's targeted therapy or immunotherapy, for any node positive. Does not suggest that you have to have 1 millimeter of tumor, which is kind of interesting because the trials were set up by stage, but the approvals are based on node positivity globally. So it's interesting to see how the practices are going to be affected by those approvals, because we certainly have to discuss risk-benefit ratios for adjuvant therapy. And even though these therapies are tolerated relatively well compared to previous adjuvant therapies, they're not candy. And there are long-term side effects that can be very serious.
To bring that back to our discussion about AJCC, now this becomes a big issue in 8 because we've split out 3A patients are now substantially less likely to have recurrence. And so we have this same issue that comes up in our practice. If someone comes in and they have a minuscule amount of tumor, they're called to be node positive, but they really have, going on a 10% risk of relapse. And then you're going to offer them a therapy which maybe has an upside absolute benefit of 5%. And you look at the toxicity profile and you've got a 5% chance of doing something severely bad. That's the kind of patient where you have to pause and really discuss things with them.
So the outlook on this is in due time, we will have at least 2, if not 3, adjuvant trials in stage 2 for stage 2B and C patients. So we are even going lower in the threshold of treating patients in the adjuvant setting, at least in a clinical trial.
But that's completely appropriate, though, because the 2C patients do worse than the 3A patients. And I think that's driven by ulceration as a very important prognostic marker, actually.
And another comment just quickly on that. When we were designing Keynote 716, which is the stage 2 pembrolizumab study, one of the things that we took into account was discussion around the changing biology and the anatomy. So as we treat patients with stage 2, we're going to have local relapse or regional relapse. What does that mean? How does that impact on our paradigm of whether or not we continue, we change? And so I think the study was smartly designed to actually capture that so that we treat patients up front, we readdress regional relapse, and we address the question that's also in Keynote 54 of PD-1 now, PD-1 later. And so we can actually start to learn over time what this new biology of melanoma recurrence looks like.